febrile non-hemolytic transfusion reactions. Febrile non-hemolytic transfusion reactions. So they are historically the most frequently reported reaction. Okay. Incidence decrease since the practice of leukoreduction, but is still more common than any reaction, especially with platelet transfusions. Before leukoreduction, as many as 1 in 3 incidents of this complication of transfusion reaction do occur. It gives rise clinically to unexplained increase in temperature of 1 degree centigrade during transfusion. We have febrile non-hemolytic transfusion reactions. Okay, what is the clinical pathophysiology of this group of transfusion complications? They are usually caused by pyrogenic substances such as the tumor necrosis factor alpha, interleukin-1 beta, interleukin-6. Okay, they are mostly released from the white blood cells. Okay, these cytokines may be produced before transfusion, as in platelets, donor white blood cells secrete these cytokines while in back storage. Transfusion simply infuse preformed fever-inducing substances. It is more in platelet transfusion. So what this sentence is trying to explain is that the pathophysiology of febrile non-hemolytic transfusion reactions as a result of cytokines that are being released by white blood cells. This type of complication mostly occur with platelet transfusion. Why is it most common with platelet transfusion? This has to do with the temperature under which platelets are being stored. Platelet concentrates are stored at room temperature. Platelet products are not kept in the fridge. At that room temperature, we store platelets at room temperature with constant agitations. But at that room temperature, the white blood cells that may be contaminating, or because in processing the platelets, the white blood cells, the neutrophils, the lymphocytes, may not be completely removed from the platelets component. So when these platelets are being stored at that room temperature, which is okay for the platelets, the white blood cells are not particularly comfortable at that room temperature. Normally they should be in fridge, 4 degrees centigrade of blood bank fridge. But because they are somehow contaminating or not 100%, the platelets are not 100% free of these white cells. These white cells that are contaminating or remaining in the platelet product tend to get agitated. That is the process. So they tend to get agitated already. And when that agitation occurs, okay, they release their cytokines, okay, pyrogenic substances, okay, like the tumor necrosis factor, interleukin-B and interleukin-6. They already released it. They already agitated and they release their cytokines already. So when these platelets are being transfused to someone that requires platelet components of the blood, you find that the cytokines are already in the system and they can give rise to these febrile reactions. Febrile but non-hemolytic, as we said. So that is one scenario through which this transfusion complication can occur. Another process through which it can occur is the cytokine may be produced after transfusion. That is for red blood cells. For red blood cells. Okay, the storage of red blood cells, as we can say again, the red blood cells we stored are not also completely free of white blood cells. There will be some contaminating white blood cells in these products of red blood cells, whole blood being stored. So in that fridge temperature, the white blood cells don't have any problem. They don't release any cytokines. They don't have any issues. But during the process of during the process of blood cross matching, you know what we are looking for. We are actually cross matching, looking for compatible red blood cell antigen and red blood cell antibodies. Particularly, we don't cross match the white cell antigens or antibody, but there are allogenic antigens to white blood cells, but we don't cross match for them. So because of that, after the transfusion, okay, this allogenic white blood cell antigen can actually elicit reactions in the donor, in the recipients, because the donor white cells and the recipient white cells were not cross-matched. So those white cell antigen can initiate uh, uh, reactions with the donor um, antibody. So cytokines may be produced after transfusion. Recipient HLA antibody, that is human leukocyte antibodies, can attack donor white blood cells, okay? Or donor antibodies attack recipients' white blood cells. Okay. This action leads to fever-inducing substances being released after transfusion. So when the uh, uh, recipient anti-HLA antibodies now attack the donor white blood cells, it results in release of these cytokines again by the white blood cells. So these are the two scenarios through which a transfused individual can develop febrile non-hemolytic transfusion reactions. They are more common with red blood cell transfusions. Okay. What are the signs and symptoms of these febrile non-hemolytic transfusion reactions? We say that the fever is transient and chills, plus rigors, sometimes no rigors, during or up to 2 hours after transfusion. Symptoms tend to occur later in transfusion. If very early, be suspicious of transfusion-related sepsis. Okay, if the fever is too early. Note that chills may be the first. Fever may be delayed up to 1 hour or more after transfusion in up to 10% of cases. Okay. Variant versions in pre-medicated or head injury patients may never have fever. Okay. There are variant versions of the reactions. Okay. Some patients that are pre-medicated, already on medication, or head injury patient may never have fever. Okay. So in a way, we need to actually differentiate. Sometimes these transfusion reactions have similar clinical presentation with each other. So in the differential diagnosis, we try to know exactly what is happening in this transfusion reaction, that we cannot or replicate the exact complication in a similar transfusion reaction. Take, for instance, we have an acute hemolytic transfusion reaction. Most acute hemolytic transfusion reaction present with fever and chills alone. Okay. It is impossible to distinguish early acute hemolytic transfusion reaction from febrile non-hemolytic reaction clinically, though most fevers in transfusion will not be acute hemolytic transfusion reactions. Okay. transfusion-related sepsis we also have, especially sepsis from platelet transfusion. Okay, red blood cell-related sepsis usually presents earlier in transfusion. So the timing of the fever presentation can be used to differentiate each of these similar presentations. So in febrile non-hemolytic transfusion reactions, we have talked about the clinical presentations. In the laboratory, we may not see negative hemolysis, okay? Negative hemolysis workup, okay? Because there is no hemolysis. You know, we say the febrile non-hemolytic transfusion reactions. How can we prevent this? Prevention of febrile non-hemolytic during red blood cell transfusion, most are due to post-transfusion WBC production of pyogenic cytokine. So leukocyte reduction works extremely well to prevent the vast majority of these reactions. So to prevent this febrile non-hemolytic transfusion reactions, we find out that there is a process, an advanced process, whereby the number of leukocytes in the blood bag can be reduced. This actually helps to reduce the leukocytes inside the red blood cells. Okay, right. So during platelet transfusion, we can also prevent febrile non-hemolytic transfusion reaction. Okay, because during the process of platelet transfusion, we have said that it's due to preformed cytokines already in the bag. Okay, the cytokines are already formed and they're already in the bag. Okay, so most are due to preformed transfusion cytokine production by WBC. So pre-storage leukoreduction is best, but there are still reactions in approximately 0.1 to 1% of platelet transfusions. So pre-storage, before the storage of the platelets, it is advised that the contaminating white blood cells be removed. Okay. So exception is soluble CD40 ligands. Okay, is platelet derived. So the soluble CD40 ligand is platelet derived. So, and it can cause fever. So leukoreduction wouldn't prevent reactions caused by this ligands, but it's minority of cases anyway. So another complication of transfusion reaction is what we call transfusion-related sepsis. That is bacterial contamination of blood products. Okay, bacterial contamination is number one infectious risk from transfusion, much more common than viruses. 1 in 3,000 platelet units are contaminated. Most contaminated products that cause reactions are closer to their expiry dates. Okay, the longer these blood products are being stored, the higher the chances of bacterial contamination and bacterial proliferation. Okay, and then bacterial proliferation. So what are the pathophysiology pathway? How does the contamination proceed? Platelets are contaminated. That is, platelet concentrates are mostly contaminated by skin contaminants from the collection process. Okay, scared collection sites can harbor organisms, and what gives a higher chance of having bacterial contamination in platelet transfusion is because for us to actually get a good platelet, the quantity of platelet products that one needs, okay, especially when we are using, even if we are using apheresis to get the platelets, or even if we are using manual procedure, you find out that one donor may not be enough to actually get the to complete one bag of donation for platelets. You require more than one donor. Okay, so that's exposure to uh, many donors makes platelets donation prone to contamination by skin organisms. Diversion pouches that accept the first 3 to 50 ml or so of collected blood in a donation are meant to harvest potentially contaminated skin bugs. It should be skin bugs. Okay. So red blood cells are more commonly contaminated by organisms growing in the donor's blood, often asymptomatic, because during the process of red blood cell donation, one donor will be enough to produce 1 pint of blood. So skin contamination, it's not a risk. um, it's only a risk during the process of platelet contamination, where we have to collect from more than 1, 2, 3 donors to be able to make up the count, the quantity of platelets we need in for one donation. So, all right, so that's why bacterial contamination for red blood cell are mostly organisms in the donor's blood that were not screened. During the process of blood donation, we don't actually screen for bacteria anyway. Most of the virus in our setting, most of the major things we screen for are the HIV, hepatitis. So we don't really go to screen for whether the patient have a malaria parasite or some other things that can actually induce fever in the recipients. So, and these things were, and the patient may be asymptomatic, donor may be asymptomatic at the time of donation, but when transfused to the donor, it may mount some immune responses and transfusion reactions. The most common organism implicated in transfusion-related sepsis is Yersinia enterocolitica. Okay, if I got it right. So contamination, this need to be updated. Product, the organisms we have, this is apheresis procedure for producing platelets. The organisms that mostly contaminate this process are Bacillus species, okay, like all these microorganisms, including Staphylococcus saprophyticus and all these ones here. Apheresis platelets, Solarine treated apheresis platelets. These are the organisms that are implicated. Then apheresis platelets, we have Staphylococcus aureus can contaminate it, and probably it's coming from the skin. Then we have apheresis platelets, split unit, Escherichia coli. We have apheresis platelets, Escherichia coli, apheresis platelet, Corynebacterium stratum. Okay, so these are some of the microbacterial organisms that can contaminate these platelet products. Bacterial contamination by implicated organisms. You see some of the organisms. These are the physical years of study: 17, 2017, 18, 19, 2020, 2021. So can see that we are still, as at 2021, microorganisms are still contaminating blood products. And as at 2021, the highest organism is Escherichia coli. Okay. So contamination by implicated products. Which of the blood products are mostly contaminated by microorganisms? microorganisms. When you look at this data, you can see as at 2018 here, okay, the same 2022, as at 2021, apheresis platelets are mostly contaminated, but as at this data here, 2022, we have a red blood cell being more contaminated, okay, and plasma, okay, plasma is no more contaminated again, okay. Pooled platelets, okay, are no more contaminated. So as at 2022, the blood product that is mostly contaminated by microorganism was red blood cell. So they are still being contaminated, okay. So organism identified depends on the products. Is it platelet concentrate? Is it red blood cell? Is it plasma? So depending on the product, there are some organisms that are mostly implicated, okay. So for the red cells, we have mostly gram-negative rods, such as this. We also have gram-positive cocci, such as these ones. Then for platelets, majority are gram-positive cocci, that is skin contaminants, including those listed above. Majority results in only mild reactions or none. We also have gram-negative rods that also contaminate platelets, can also contaminate, and are much more likely to cause fatalities than gram positives. Okay. So plasma products, for plasma products are not commonly contaminated, okay, and few reports are linked with when placing the plasma on water bath. Okay, the contamination species mostly Pseudomonas species. Okay, the signs and symptoms of bacterial contamination of blood products. We have rapid onset of high fever. Rapid onset of high fever. It's rapid. Okay, the onset of the fever is quite rapid and is often high, greater than 4 Fahrenheit or 2 degrees centigrade above the basal body temperature. We have rigors, that is true shaking and chills with rigidity. Okay, you have abdominal cramping, you have nausea, you have vomiting, hypotension, shock. So the clinical um, presentation for bacterial contamination of blood products is quite dramatic. Okay, so we also have some differential diagnosis trying to differentiate this bacterial contamination of sepsis, trying to differentiate blood contamination with bacterial sepsis from acute hemolytic transfusion reaction, from anaphylactic transfusion reaction. All these have fever, febrile non-hemolytic transfusion, sepsis from non-transfusion sources. So you need to actually look in details to be able to differentiate the fever due to one or the other of this somehow similar presentation, but with very subtle differences amongst them. So acute hemolytic transfusion reaction, always acute hemolytic transfusion reaction, you know, we said there is almost a total shutdown of the organs of the body. Acute hemolytic transfusion reaction that was due to ABO incompatibility. You know, the presentation is quite catastrophic, okay, because of the hemolysis that is happening, okay. Severe septic reaction, however, usually are more acute and dramatic in presentation than the typical acute hemolytic transfusion reaction. Anaphylactic transfusion reaction. Anaphylactic transfusion reaction can also be dramatic and very early in the transfusion, but usually not febrile. Okay, anaphylactic transfusion reactions, okay, are not febrile. Okay. You have febrile non-hemolytic transfusion reaction. They are milder septic reactions, and many platelet contamination can overlap with febrile non-hemolytic transfusion reactions significantly. As a result, many culture units as part of febrile hemolytic transfusion workup protocol. So because you know that in platelet febrile non-hemolytic transfusion reaction due to platelets, we are not implicating any microorganism. So, but in transfusion reactions, sepsis transfusion reactions, when you do the culture, you'll be able to isolate a microorganism that's actually implicated in the fever. Sepsis from non-transfusion cause, infected lines, and all fluid coincidental presentations. Okay, right. So diagnosis of um, transfusion-related sepsis. How do we diagnose transfusion-related sepsis? First of all, we have to get the unit of blood. If it's red blood cell that is being implicated, you find out that the red blood cell, there's discoloration. Okay, red blood cell, because the bacteria are inside there growing, proliferating, multiplying, there is tendency for the color of the red blood cell to be darker. Okay, so contaminated red blood cell may turn dark or purple. So before any transfusion, you normally check the coloration of the blood. You look at the blood very well. Okay, so we also see hemoglobinemia, hemoglobinuria. Okay, that's negative unless it's coincidental. Okay, because maybe coincidental, that now we are not talking about antigen antibody reactions in sepsis related uh, transfusion contamination. We're talking about bacterial contamination, so that may be negative. Gram stain may be positive because we are looking for microorganism that's gram positive cocci. Okay, source of the gram stain and culture is very important. Avoid culturing or staining a segment. Okay, remember to also culture associated IV fluid, and consider that an indwelling IV catheter may be a source of contamination. So during the process of culturing, when we are suspecting bacterial contamination of the blood products, first we culture everything, both the donor, okay, the donor, yes, we culture the donor, we culture the blood bag, we take sample from inside of the blood bag, we also take sample from the 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 the, the tubes. Okay, you can also get from the tubes of the blood bag. Okay, then if there are any IV fluid that are being given at the same time, we also culture it, and then culture the recipients. So in a situation where we do the culture properly, aseptically, okay, and we find out that an organism that was identified inside of the blood bag was also present in the donor, okay, in the donor patient, okay, and also it's now being transfused to the recipient, now present to the recipient. There is more suspicion that the organism is actually coming from the donor. Okay, so we culture everything along that pathway of transfusion to be able to pin down exactly where the bacterial contamination is coming from. So culture is proof positive when some organism is cultured from both unit and recipients, even better if from the donor as well. So every chain, all the uh, Persons along that chain of transfusion and the blood bag has to be cultured. Okay, how do we manage sepsis-related transfusion reactions? So immediate IV antibiotics, pressure respiratory general support as needed depending on the presentation of the patient. If it's gasping for air, support as needed. Then you have to quarantine all other products from the same donor when it has been proven that the contamination is also present in the donor himself or herself. Prevention. To prevent sepsis-related transfusion reaction, we have to pay careful attention to donor history documentation. Proper phlebotomy technique, use of diversion pouches is mandatory so that when the needle puncture is being done, the first flow of blood are not allowed to get into the blood bag because they are definitely coming in with skin contaminants. So there's a diversion pouch where the first part of blood flow should move to before the rest start flowing into the main blood bag. That's what we mean by the diversion pouches. Then also leukocyte reduction filters may decrease risk. Okay, especially in Yersinia concentration, routine detection of platelet contamination, pathogen reduction. These practices can help reduce sepsis-associated transfusion reactions. All right. So we also have transfusion-related acute lung injury. Transfusion-related acute lung injury. So everything along that term adds something to the pathophysiology or the mechanism of action of the complication. It is transfusion related, it is acute, and it's affecting the lungs. And it's as a result of the transfusion the recipient received. So definition, we call it Raleigh. It's a syndrome of acute hypoxia as a result of non-cardiogenic pulmonary edema that follows transfusion. Non-cardiogenic pulmonary edema that follows transfusion, Raleigh. Okay, or it can be defined as new acute lung injury. The patients have never presented with lung injury, but after transfusions, you find out that the patient or the recipient now developed an acute lung injury, which is quite new. In less than 6 hours after transfusion, you find out that the patient started presenting with lung injury, hypoxia, see? So acute lung injury is defined as hypoxemia with partial oxygen saturation of less than 300 millimeters of mercury, or acute oxygen saturation of less than 90%, and bilateral chest X-ray infiltrates. That is what we observe when we carry out the chest X-ray. Okay, so usually also it presents with fever, chills, transient hypertension, then the hypotension comes in. Platelet plasma transfusion are most often, but also with red blood cells. So this complication occur mostly with platelets or plasma transfusion. Transfusion-related acute lung injury, hypoxia. Okay. The incidence varies widely, 1 in 1,200 to 1 in 1,900 of plasma containing transfusion. The clinical differential diagnosis include the common symptoms. We have fever, chills, hypertension, then hypotension. Plasma-rich products are mostly implicated. Clinical or differential diagnosis, acute respiratory distress syndrome. We can differentiate trially from acute respiratory distress syndrome. TRALI may look exactly like acute respiratory distress syndrome, but TRALI usually resolve in 24 to 48 hours. Transfusion-associated circulatory overload may also be identical to TRALI clinically, complete with a wet chest x-ray, okay, but TRALI is usually associated with fever, unlike TACO, okay, and does not respond to diuretics. Okay, TRALI does not respond to diuretics, okay, but TACO, transfusion associated circulatory overload, responds to diuretics. Okay, so again, if there are any transfusion complications that have similar clinical presentation with another one, you sit down and try to form something like a tiebreaker, what you will use to exactly say that this should be this complication and this should be this complication. You should be able to do it. You can see how we are mentioning fever all along. How does the fever present? At what point in time? How long does it occur? Which other presentation can add to differentiate the other one from the wrong? This is something you have to sit down by yourself and try to resolve it very well. So we have also anaphylactic reactions, acute pulmonary and myocardial disorders. So you should know how to differentiate TRALI from all those complications, all other complications. Okay. So these are some of the mortality, fatalities by implicated product for TRALI. Find out that as at 2021, 1, 2, 3, 4, okay, all the blood products, okay, we still have a FFP, red blood cell, apheresis platelets, multiple products, FFP, that is fresh frozen plasma, are still implicated with TRALI, okay, in TRALI. So yeah, so what is the disease mechanism of this TRALI? Why should it occur? Transfusion related acute lung injury. Currently, there are two acceptable pathways that try to explain this pathophysiology of TRALI. We have neutrophils in the pathophysiology of TRALI. Neutrophils playing a very significant role in the development of TRALI. We have the donor antibody pathway for TRALI. Here we have the anti-HLA or anti-neutrophil antibodies from the donor binds to antigens on the recipient's neutrophil. Recall or remember that we said during the process of blood cross-matching that we match specifically the red cell antigens and the antibodies of the donor and the recipients. Okay, that during that process, we do not specifically match their white blood cell antigens. And we've said that white blood cell antigens exist. We have allo white blood cell antigens and allo white blood cell antibodies. Okay, they exist. Okay, so this HLA or anti-neutrophil antibodies from the donor, because they were not cross-matched with that of the recipients, they can elicit reaction, okay, by triggering off the recipient's neutrophils when the antigen antibody do not match, and in most cases they don't match, so they still trigger off that reaction. So antibody neutrophil complexes, okay, so this antibody and the neutrophil complexes that are being formed deposits in pulmonary vasculature and activates the polymorphonuclear bactericidal responses. Okay, so because these donor anti-neutrophil antibodies are being transfused and they form complexes with the recipient's neutrophil, okay, these complexes are now being deposited on the pulmonary vasculature. And when that's happened, they tend to activate. When they are being deposited, the body immune system will try to fight. Okay, when these complexes are being deposited, the body will try to fight because they see them as invaders. So in trying to do that, the white blood cells are being activated. When they are activated, okay, they start to release their cytotoxin oxygen toxic oxygen radicals and bactericidal enzymes. Okay, so the release of these oxygen radicals and bactericidal enzymes by the neutrophils, okay, leads to damage to the pulmonary endothelial cells of the lungs lining the capillaries, with the resultant leakage of fluid into alveolar spaces. So this mechanism may also occur with recipients' antibodies against donor white blood cells. Okay, but this pathway is less common. Okay, that is how the trial can come up. So this is just a picture trying to dramatically show the pathway to trialing. These are the recipient's white blood antibodies. Okay, when the donor's antigen antibodies, these are the recipient's antigens, white blood cell antigens, then the blood products that are being transfused with neutrophil antibodies, okay, forming complex with this forming this complex, which are deposited on the pulmonary vasculature. Okay, when that happens, they also triggers off the body reactive mechanism in trying to fight them to release the oxygen radicals and bactericidal enzymes, which tend to damage the endothelial structure of the pulmonary vasculature, okay, which may now allow fluid to escape into the alveolar spaces, causing the transfusion-related acute lung injury. Okay, so that is basically the scenario. Okay, so here they are trying to explain it in event pathway depending on the condition. Okay, this slide is just trying to um, explain the physiological conditions that may also help to promote such mechanism from occurring. Okay, so pre-transfusion condition that activates lung endothelial cells and prime polymorphonuclear cells prepares them for microbicidal actions. Okay, so sometimes the recipients may not be sound, may somebody that already have some sepsis, and the activation put the patient in a state where additional push could start the process. Okay, so transfusion of stored blood products and antibodies and all that can give rise to these are physiological explanation to the event pathway. So still the same thing. So let me not go there so that you don't get confused more. So diagnosis of trialing, bilateral chest x-ray infiltrate, oxygen saturation less than 90%. So if the x-ray is being carried out, we'll observe this bilateral chest x-ray infiltrate. There are no evidence of volume overload That is, when you look at the neck, when you observe the jugular veins, you find out that the jugular veins on the neck are not distended. That is, they are not distended, they are not overloaded. Okay, although the person is suffering from respiratory distress, lung injury, but there are no overload, unlike in taco, where we still have respiratory distress, but you find out that the jugular vein are distended. Okay, no jugular venous distension, normal wedge pressure, normal BMP levels. Okay, lab findings may include demonstration of anti-HLA and or anti-neutrophil antibodies, and possibly increased biological response modifiers in the bag. This is a clinical and radiological diagnosis. Confirming the presence of a donor antibody may take days or weeks. So mostly to evaluate trially, we say that it's mostly a clinical evaluation and then the radiographic diagnosis, that is the chest x-ray, because before we will finish confirming antibodies to the white blood cells, it may take us some time. So the diagnosis is mostly by performing the clinical presentation, observing the clinical presentation, and also carrying out chest x-ray. Treatment is mainly respiratory support. Mortality reports between 5 to 25% and 80% recover quickly. Prevention, implicated donors, that is with antibodies, should be deferred from donation. Use of male plasma has been shown to decrease the risk of trialing. Females have more anti-HLA and anti-neutrophil antibody because of multiple pregnancies. Because of multiple pregnancies, they have developed a lot of HLA antibodies in their system. So most of the times, women that have given birth multiple times are not allowed to donate blood because of the higher risk of having anti-HLA antibodies. Testing paros female platelet donors for anti-HLA neutrophil antibody and differing those who have antibodies. So if it is necessary that a woman should donate platelets, it's advised that we screen for anti-HLA antibody, especially in women that are multiparous. Okay, we have another type of transfusion reactions we refer to as acute reactions presenting without fever. We have been dealing with acute reactions that are presenting with fever. In our classification of transfusion reactions, we classified transfusion reaction based on the time of start, the time of presentation into acute and delayed, and also we classified based on the presence or absence of fever, febrile, non-febrile, acute or delayed. So acute reaction presenting without fever. Under this, we have the allergic transfusion reactions are the most common adverse reaction to transfusion therapy. Different forms are recognized with regards to severity of the reaction. It can be mild, it can be moderate, it can be severe. Anaphylactoid for moderate, anaphylaxis for severe. The mild allergic reactions, called the urticaria cutaneous transfusion reactions, they have incidence of 1 in 3% of transfusion of plasma of platelets and 0.1 to 0.3% of red blood cell. That is the incidence of occurrence in these products. The clinical presentation include localized hives, as you can see in this slide, angioedema, okay, severe swelling around the eyes and lips, mild respiratory symptoms, and laryngeal edema. the mechanism of this allergic transfusion mild allergic transfusion reaction is as a result of type E hypersensitivity to transfused plasma proteins. Okay, most mast cells secretion of histamine and resultant cytokines and other mediators of allergic reactions. So that is that. Then the treatment can be as a result of some drugs, products, can also wash the products, restart the transfusion after the hives have cleared. For the moderate allergic transfusion reaction, which we refer to as anaphylactoid transfusion reaction, some allergic reaction fall between the two classic categories, may present with upper or lower airway obstruction, cutaneous modification, upper airways of obstruction, where you observe the as a whistling sound, okay, in the throat. Lower airway, see like wheezing, chest tightness, dyspnea, okay. Then severe allergic transfusion reaction. Definition: allergic reaction that results in shock and hypotension. Meanwhile, they don't present with fever, okay, seen in those with undetectable IgA levels, okay. Other causes include haptoglobulin deficiency, latex drugs, foods and donors can lead to severe reaction in susceptible patients. Sometimes you say donors don't eat because some after eating can I don't know how that will possible. It can contribute to some transfusion reactions. Okay, the incidence is 1 in 20,000 to 50,000 transfusions. Okay, clinical presentation: anaphylactic shock very early in the transfusion, respiratory symptoms with acute hypotension, GI complications, skin findings. We have urticaria, angioedema, generalized pruritus. Okay. For diagnosis of allergic transfusion reaction, check pre-transfusion sample for serum IgA levels. Those with very low undetectable IgA levels should be tested for anti-IgA. Okay. Differential diagnosis: acute hemolytic transfusion reaction, typically febrile. Most acute hemolytic transfusion reaction don't present this early. Septic transfusion reaction, high fever and lack of skin finding. Okay. Acute hypotensive reaction, this reaction have hypotension only without respiratory or skin finding. The treatment is that. Okay. Prevention: IgA deficient product traditionally given for those with demonstrated antibodies. IgA deficient option: wash cellular products, okay, autologous unit. For patients with no demonstrable IgA deficiency, wash cellular product and autologous unit. So some of these allergic reactions can be handled by washing the product to remove any IgA that can initiate such responses in the recipient. Acute hypotensive reaction. CDC definition of acute hypotensive reaction is increase in greater than 30 millimeter mercury drop in the systolic blood pressure with diastolic less than 80 millimeters of mercury. It occurs less than 15 minutes after the start of transfusion and resolve within 10 minutes after transfusion has stopped. Reactions are similar to severe allergic reaction, but only have severe hypotension and there's no skin finding, no GI complaints, no respiratory issues. Okay, it's just the hypotension that occurred, and this can happen as a result of some patient taking some drugs, like patient taking angiotensin converting enzyme inhibitors. Okay, so rapid onset of flushing and hypotension in transfused patients who are on this angiotensin converting enzyme inhibitors, probably caused by accumulation of increased bradykinin, okay, or bradykinin metabolites generated during the storage. ACE inhibitor prevent full metabolism of bradykinin. The bradykinin metabolite causes marked but transient hypotension. So it mostly occurs in patients that are on ACE drugs. Patients receiving blood through negatively charged filters, okay, seen mainly with certain negatively charged filter bedside leukoreduction filters. That's where we can also see that. Also seen in therapeutic apheresis procedures, okay, reported with reinfusion of intraoperative blood that is filtered before infusion. So there are some practices or therapeutic procedures that can predispose the recipient to developing this transfusion acute hypotensive reaction. Clearly, a diagnosis of exclusion, you have to rule out other transfusion reactions before you can now suspect acute hypotensive reactions. The management is to stop the transfusion, give fluids, consider epinephrine if not resolved promptly. Prevention is prophylactic measure, not necessary. Prophylactic measure is not necessary. Avoid bedside leukoreduction filters, the things that can actually lead to acute hypotension. Stop ACE before therapeutic apheresis procedures. Okay. I think we should stop here for now so that we'll be able to explain TACO the next time, because TACO is quite not huge. Okay, though, so we'll take it. It's only TACO, so we have to take it. I have to take it. I don't have to defy it. The slide is finished. So another transfusion complication we have is transfusion associated circulatory overload. We call TACO. Transfusion associated circulatory overload. The definition is that it's acute onset of congestive heart failure as a result of blood transfusion. Okay. Dyspnea, autopnea, bilateral rails with hypoxia, systolic hypertension, okay, tachycardia. These are some of the clinical presentations. It's usually afebrile on X-ray with bilateral basilar infiltrate. Patients with pre-existing congestive heart failure, very old patients, okay, renal failure, chronic anemia patients. These are patients that can easily present with such disorder during transfusion. TACO fatalities, okay. When you look at TACO fatalities, find out that it's on the increase. Okay. So diagnosis is hypoxia, less than 90% saturation on room air, bilateral chest X-ray infiltrates, reaction occurring within 6 hours of transfusion. Differential diagnosis, we have to differentiate TRALI from TACO. Okay, we said that clinical response to diuretics, positional changes in TACO, okay, fever in TRALI. So in TACO responds to diuretics because it is an overload, circulatory overload. So it will respond to diuretics. Why TRALI? There's no circulatory overload. It's just that the white blood cells are releasing cytokines and oxygen radicals that are destroying the endothelial lining of the pulmonary capillaries and allowing the fluid to escape. Okay, that is what is causing the respiratory distress in trali, while in taco it's as a result of circulatory overload. And majorly occurred in those patients, like old patients, patients with sickle cell disease anemia that are being transfused with full blood. Okay, say they mostly can occur in patients with pre-existing congestive heart failure, can suffer from TACO. Very old patients can be predisposed to TACO. Patients with renal failure, chronic anemias like in sickle cell disease, thalassemia, that are being transfused, especially if they are being transfused whole blood instead of giving them packed cell. Okay, because of the chronic transfusion, it's of transfusing whole blood, they have a tendency of being exposed to circulatory overload. Okay, so that is the differential diagnosis, how you can differentiate trali from TACO. Respiratory distress are involved in two of them, but that of TACO can respond to diuretics. Okay, and that of trali cannot respond to diuretics because there is antigen, there's reactions that is damaging the endothelial lining of the pulmonary capillaries, allowing fluid to leak. Okay, finding anti-HLA or anti-HNA antibodies as above establishes trali and not TACO. Okay, so treatment is to stop the transfusion, evaluate, sit patient up, give supplementary oxygen, diuretics to decrease the blood volume. In severe cases, therapeutic phlebotomy may be indicated. Prevention in at-risk patients, we can prevent that in at-risk patients by controlling the transfusion rates, split the unit into aliquots when possible, consider low volume units or volume reduction of certain products. So these are the table showing some comparison between trali and TACO. Patient characteristics for trali, more common in hematology and surgical patients, most common in aged patients. Okay, implicated blood components for trali, mostly plasma or platelets. Anything can cause TACO once there's overload. Okay, onset up to 6 hours from transfusion, this within 6 hours. Okay, oxygen saturation is reduced. It's also reduced in TACO. Blood pressure often low. In TACO, it's high because there is overload. Jugular vein pressure is normal or low. In TACO, it's elevated. Temperature often raised. In trali, is normal. In TACO, chest X-ray, bilateral prealar and nodular shadowing, or white out, heart size normal. You can meet your colleagues in radiography to explain more. Enlarged heart and characteristics of pulmonary edema for TACO. Echocardiogram is normal, is abnormal in TACO. Pulmonary artery wedge pressure is normal and trali is elevated in TACO. Blood count fall in neutrophil monocyte followed by neutrophil leukocytosis, no specific changes in TACO. Fluid challenge improves, worsens in TACO. Response to diuretic worsens, improves. So these are some of the differential diagnoses of trali and TACO. Okay. All right. Thank you for listening. Thank you very much. If you have any questions, you can go ahead now and ask. Unmute yourself and ask your question.